A 21-year-old male patient presented with intractable hyperhidrosis involving his palms, axilla, and his feet. The severe palmar sweating interfered with his activities of daily living as well as his ability to work. He was seen for a surgical opinion after he had failed conservative therapy. Bilateral thoracoscopic sympathotomy at T2 was recommended and informed consent was obtained. The patient is positioned supine with a soft pillow roll placed behind the back and with both arms extended outward on padded arm boards. Temperature monitors are placed on both palms and labeled right and left respectively on the anesthesia monitor. After isolating the left lung, we start by placing a 5 mm thoracoport in the 6th intercostal space in the anterior axillary line. CO2 insufflation to a pressure of 6 mm of mercury is used to help with exposure. A second 5 mm port is then placed under thoracoscopic vision in the 3rd intercostal space in the anterior axillary line, and a blunt grasper is introduced through this port to help mobilize the lungs and count the ribs. The sympathetic chain can be seen running vertically across the head of the ribs. The second rib is identified and the sympathetic chain at the level of the second rib is chosen for sympathotomy. A hook cautery at a very low setting is used to open up the pleura on either side of the sympathetic chain at the level of the second rib. After exposing the sympathetic chain, it is divided transversely, completely separating it. We evaluate for any accessory nerves and, if present, carry the cauterization across those nerves. Successful sympathotomy is confirmed by an increase in baseline temperature in the corresponding palmar temperature probe for that side. A bronchial tube exchanger is advanced through the upper port into the pleural cavity, and the lung is reinflated under thoracoscopic vision. This allows the CO2 to be evacuated through the port while the external end of the tube exchanger is held underwater. A Valsalva maneuver is then performed to expel all the CO2 from the chest. We now turn our attention to the right side, where incisions are made in an identical fashion to the left, and sympathotomy is performed again as described before. A postoperative chest X-ray is obtained while the patient is still under general anesthesia, and if a significant pneumothorax is identified, a chest tube can be placed. In this case, the patient was discharged home on the same day following procedure and had complete relief of his palmar hyperhidrosis. He had no evidence of compensatory hyperhidrosis.